Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Bert Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Bert Kushner.
Welcome to the One World, One Vision comprehensive course on strabismus and today's lecture on thyroid eye disease. If you're new to this series, I'm glad you're here. And if you're a repeat viewer, I'm happy that you're back. Today we have two speakers. Dr. Shira Robbins is Professor of Ophthalmology at the University of California in San Diego, where she is also the president of the medical staff. And Dr. David Granet, who is the Ann F. Ratner Professor of Ophthalmology and Pediatrics, also at the University of California, San Diego. With pleasure, I turn this over to Dr. Robbins.
Thank you very much, Dr. Kushner. And first, I really want to express our appreciation to both Dr. Kushner as well as Dr. Lederman for putting together this wonderful collection of talks on strabismus. But more importantly, I want to thank you, the listeners, because you have the opportunity to take care of these patients with this devastating disease and make such an impact in their lives. Thyroid eye disease is known by many names: thyroid-associated ophthalmopathy, Graves' ophthalmopathy, and many more. Dr. David Granet is an educational speaker on the panel for Horizon Therapeutics and will be discussing some of their treatments later on in the talk. This disease process was described quite a long time ago by a Persian physician and philosopher. In more modern times, in the 1800s, Perry, Graves, and von Bassadel also published on this association. This disease crosses specialties, both within ophthalmology and beyond ophthalmology. And because of this multidisciplinary disease issue, we started the Thyroid Eye Center here at the University of California. There are also multiple research entities which have included this multi-specialty phenomenon, one in Europe, the UGOGO, and one internationally, the ITEDS. So who gets this disease process? Well, Graves is a very common disease, and the folks that go on to develop the eye findings, it's much more frequent in women than in men, but when men get it, it seems to be more severe. 1/3 to half of patients with Graves' disease get the eye findings. And because most people with thyroid disease have Graves' disease, that means that most people with a thyroid eye disease have Graves. Although you can see the eye findings in patients who are hypothyroid and even euthyroid. Patients can develop the eye findings either before their diagnosis of thyroid condition is made or during the same time, coincidental, or also afterwards. And sometimes even without a detectable thyroid abnormality, you can have the eye findings. So what's actually happening on a cellular level? Well, this is an autoimmune issue, right? And so we have the immune system, which is attacking both the thyroid as well as the eyes, because it's going after a shared antigen. So even if we fix the thyroid, we still may not fix the eye issues. So on a cellular level, we see all of this inflammation followed by fibrosis. And on the muscle level, we see this gross enlargement, which spares the tendons. When we look at this from a radiologic perspective, you can see on the right-hand side the normal, and on the left-hand side these grossly enlarged muscles sparing the tendons, and here in the coronal sections. The two stages of development are the active and then quiescent stages. And in the active stage, we have a classic red sore eye, which has really changed someone's cosmesis. And typically, if left alone, they go into more of a remission period within 3 years. In the quiescent stage, the eyes are typically much more white, but there can be these painless motility issues. And then, of course, some of the more severe findings of exposure keratopathy or even optic neuropathy, which can lead to permanent loss of vision. So the signs of thyroid eye disease, we have eyelid retraction. The eyelids can get hung up when looking down. The eyes are pushed forward, which leads to dry eye and exposure keratopathy, conjunctival injection and chemosis. The eye muscles become enlarged, leading to diplopia, and sometimes pain with eye movement. The entire orbital area can become edematous, and then the optic nerve dysfunction can be present as well. Strabismus issues has a predilection for certain eye muscles. The inferior rectus is much more involved in this disease, followed by the medial, the superior, the lateral, and then the obliques. There is, however, ethnic variation. So in different parts of the world, this can change. It's important when we consider the differential diagnosis to understand that because this disease oftentimes manifests as a classic looking red eye, that there's oftentimes a delay in the diagnosis because these patients are treated as simple cases of conjunctivitis, perhaps an allergic conjunctivitis. But once the orbital signs and motility issues are recognized, we have to consider the full range of differential diagnosis. We work them up typically using a blood panel. Then when the blood panel is negative, if you have a clinical suspicion, you can dig a little deeper and get thyroid autoantibodies. It's very helpful to have an endocrine specialist help us at this point. Radiology is very helpful as well, especially looking at the orbital apex. Getting a CAT scan is oftentimes faster and cheaper, but we do have to understand the radiologic content as well. These patients are confused, and they're confused because they're told that they have a thyroid disease, but then their eyes become involved as well, and it's very hard for them to understand it. In addition to being confused, they're frustrated. They're frustrated because this disease process suddenly comes on, completely turns their lives upside down. They look in the mirror, they're not who they were before, and it can take several years for them to get to that point of improvement, as you can see here in the classic Rundle's curve. And even knowing that, up to 6 of these cases, even after several years and they're in that improvement phase, although not quite at their baseline, can have reactivation. And then they become depressed. Dr. Granet, would you like to comment on the depression in these patients?
Shira, this is one of the most important things that I've encountered in treating patients with thyroid eye disease. We started seeing patients in the office crying one after the other on our thyroid clinic days. So we embarked on a study where we looked at 2 groups, each of whom have thyroid disease, but only one group had the eye signs. And what we found is there was a significant difference in the psychological impact to the two. And I was really surprised to find out that disfigurement was worse than diplopia or functional change. So the change in the appearance hit people harder. And when I say hit people harder, I'm talking about psychological changes of anxiety and depression that are on the same level as cancer and AIDS. This is a big deal. And as specialists dealing with these patients, we need to keep in mind how much it's affecting them and the whole person that we're taking care of.
Thank you.
And it's really helpful, I think, to have a guide as you think about treating patients. And our 5-step guide is what you see: medical treatment, followed by prisms and even Botox at times before the patient's stable. Once the patient's stable, we do decompression if they need it. Then we finally do the strabismus repair, followed by the lid repair. If you do the strabismus repair after the lid, you'll find that the lid shifts. And we'll talk about that as we go along. There are some changes that take place in this, especially optic neuropathy, that make us change approach. Although it's a serious complication and one we worry about, fortunately, it doesn't happen that often. About 5% of patients might develop some form of optic neuropathy. It's important to recognize why that occurs. And if you look at the CAT scan that you see here, you'll see the fusiform enlargement of the muscles compressing the optic nerve as it goes through the optic canal. That's typically where this takes place. If that happens, you start to see changes in color vision, impairment of visual acuity, central scotomas, other visual field defects, etc. And the patients usually notice that they're not seeing as well. And then that forces you to go ahead and do a decompression. Typically, what we see is axial proptosis in the thyroid patients. And if you think about it, there's no room in the orbit other than to go forward. So the eye gets pushed forward as the fat and the muscle increases in size. And as that happens, that is unchanged by the treatment of the hyperthyroidism. That's the part that Dr. Robbins was talking about that frustrates people. They don't understand it. They have thyroid eye disease and their thyroid levels are normal. So why is their thyroid eye disease still going on? And that's up to us to explain the issue of an autoimmune disease. When we're measuring proptosis, you'll see in some textbooks, it says normal is up to 21 millimeters, and then above that's abnormal. But actually there's huge ethnic and interpersonal variations. So what we look for is the delta or the change. If I start with deep set eyes at 13 millimeters as measured on a Noggle exophthalmometer, then I go to 15 or 16. Boy, it looks normal on a scale, but that's a 3 millimeter change for me. So the change for that person really matters. We often will pull old pictures, or what some people have jokingly called a FAT scan, family album scan, to look and see what the change is on a patient. Some people come in and they look quite normal because you've never seen them before, but to them, it's a large change. So what do we do for these patients? Some people use systemic steroids, others use low dose radiation, but we find that surgical decompression has been our go-to, especially with some of these with autoimmune problems like diabetes. In addition, radiotherapy can be an issue and steroids can be problematic. Our group looked at decompressions led by Don Kikawa here. And what he showed was that you can divide how much you want to get done into 3 different grades: a 1-wall, a 2-wall, and a 3-wall, and get predictable changes in the proptosis of the patient. So it allows us to actually really plan for what the patient will look like. Here's a patient with a large amount of proptosis, had a 3-wall decompression. As you can see, the eye is now set back and her lashes and the globe aren't touching her glasses when she's just going out and about. There are other changes that take place when you do a decompression. You never get to do something with that as a free card. Always there's a secondary interaction that takes place. And when we do a decompression, if we look at the muscles, you'll see as the eye comes backwards, the muscles increase in volume. So there is a change that takes place. Now remember, sometimes you do a decompression for optic neuropathy. If the eye goes back and the muscles get larger, you might run into a problem with what's happening with the patient. It also can change the alignment. Another reason why we do strabismus after the decompression, because these muscles that are so large now have room to move around, and they may well move around. So that leads us to the functional deficit. It's one thing to drive in traffic like this, and it's another like this. And nobody wants that particularly. So that's up to us then to straighten the eyes out. Now, Dr. Robbins talked to you about the order that the muscles are normally involved. And we use the acronym I'm slow, which was taught to us by one of the residents who used that to remember the order of the muscles involved. But why is that order? There's some work that came out of the University of California in Irvine that demonstrated that the amount of troponin T in each of the muscles is different. And as Graves' disease progresses, you'll see that the inferior has more troponin T and then the medial and so on. It may well be that which is related to mitochondrial activity, why the muscles differ in size. So that gives us at least some pathophysiology understanding. Up to half of the people with a dysthyroid problem end up having functional deficits in the form of strabismus. That diplopia sometimes gets better if it's small, but often not. And typically early on, it's a contracture that stops the eye from moving normally. And then later, during the infiltrative and fibrotic phase, you end up getting a muscle that's just stuck and won't really give. So we started looking at different options. And one of them we said, was there anything that we can do, for example, using Botox? And along with our group that does our decompressions, because as Dr. Robbins mentioned, we see the patients at the same time, we decided to try botulinum toxin as an aid and adjunct to decompression. And under direct visualization, the Botox is given in much larger doses than is typical. And we usually did the medial or the inferior rectus, and we presented this at the North American regional meetings that were done in Orlando several years ago. So here's a patient that had a 2-wall unilateral decompression. As you can see, her left eye is lower than the right, and we did Botox to the inferior rectus. That's the only treatment she got, and she did not need strabismus surgery. Somehow that made our oculoplastic surgeons very happy that they could now treat strabismus, but we were pleased too because it's better for the patient. So does it really work all the time? No, but it is something that you can add during the decompression to help our frustrated patients. Now, before that, we've been trying to use prisms, for example. If you use prisms, they can work, but prisms don't work very well for a patient who has an incomitant deviation, nor do they work well for people who have very large deviations. But small, mostly comitant deviations can do very well with prisms. And then you can use Botox even before a patient is stable, and then eventually surgery, whether it's before decompression, if there is no decompression, or after if there is a decompression. So what happens with Botox as a treatment alone, and we do these in the office for patients with an ocular deviation from thyroid eye disease? What we found is if the deviation is greater than 20 prism diopters, the success was not very good. That only about 18 to 20% of the patients were able to have significant enough improvement that they didn't need surgery. However, many of the patients saw their deviation improve, and thus the surgery they needed was less. And if the deviation was less than 20 prism diopters, we saw 30 to 50% were able to avoid surgery. So what we found is that if the deviation is smaller, Botox has a really good role, and that even if it's larger, it may reduce the amount of the deviation that you eventually have to operate on. However, nothing comes without a secondary consequence. And what we saw is 3 of our patients ended up developing optic neuropathy. Think about it. We're adding fluid to a muscle that's already large, and we're shifting its position in the orbit, and so thus in the optic canal, the nerve can get compressed. So these become important issues to remember, that each of our treatments may have a secondary issue. And in terms of secondary issues, one of the things that we looked at was the pressure in the patient's eye. And we had several patients that noted that they had glaucoma, and it was recently diagnosed, some even scheduled for glaucoma surgery. But we found that when we did the Botox injections, we were able to lower the pressure in the eye. And we know that when people look up, their pressure increases. And if you think of the fusiform shape of the inferior rectus and how tight it gets, you can imagine it pushing on the globe and the pressure going up, especially at night when the patient might be sleeping. Well, when we do the Botox and we allow the muscle to move more easily, what we find is that the intraocular pressure goes down. Similarly, we look when we do strabismus surgery and the intraocular pressure also goes down. And so this is an important thing to keep in mind if you have a patient who's recently diagnosed with glaucoma, or the glaucoma is becoming frustratingly difficult to treat, that it may have something to do with their intraocular pressure from the thyroid eye disease. Decompression also can lower the pressure. So all of those will help the patient who has elevated pressure. Now, strabismus surgery in a patient with thyroid eye disease is difficult, and planning is everything. Thinking through the disease and understanding how you're going to approach the problem really is what makes a difference for the patient. And we use two basic principles. I first heard Art Jampolsky from San Francisco elucidate, and Bert, you may have some other input on that, having heard this way before I had. But he used to say in adult strabismus, if there is a restriction, release the restriction, and if that's not enough, try and match the duction deficit. And we use that thinking when we do thyroid eye disease. We also developed an approach to the planning of any adult strabismus, but specifically in thyroid eye disease, by drawing out the previous surgery they may have had. Often people come to us with previous surgery and they need more. So by drawing it out, and we publish this, as you can see the title there, you are able to visualize the strabismus and see what you want to do next. Every ophthalmologist recognizes what's right in the middle of that picture, for example, an intraocular lens, or that the medial rectus may have been recessed. The dotted lines indicate decompression, and a syringe indicates a Botox injection. And we have a whole nomenclature that we've used, and it really helps. Our fellows over the years have helped us come up with that kind of approach. And for every patient that we see, we have a preoperative planning sheet that we develop that has all the information that we need, including the drawing of what they had previously, if they did have previous surgery, and what our options for plans are, so that in the operating room, we can put that sheet up. That idea came from when I visited Dr. Marshall Parks in Washington, D.C., and he had a little sheet that he had what he was planning to do for each patient. We developed that over time into this planning sheet for the most difficult and complex patients. That really makes a difference for us as we plan. So what else have we noticed? We noticed that there are these patterns that we see in strabismus that include things that you might not expect. Now, we looked at the 3-step test as we did this, and although you see it says an overaction pattern in thyroid disease, we know that's a restrictive pattern. But if you try and apply the other tests that we're so used to using, it looks like an overacting pattern rather than a restriction pattern. And what you notice if you look at this is that often it looks like the obliques are involved. And if we remember Hering's law, you'll see that the contralateral oblique might be involved when you have one muscle that you're trying to move and you're ramping up your innervation. By Hering's law, if it's a rectus, the contralateral oblique is going to be involved. And so we see those kinds of patterns, which leads us to think that there are times when we might have to use the obliques to help us in this surgery, although they're not usually involved in thyroid eye disease. They can be, but they're not usually. But to help the incompetence that we see, sometimes we have to go to an oblique muscle. So what are our goals? Most patients we need to get to be able to see straight ahead, and that's obviously key. And then secondarily, we'd like to get reading position. When you're weakening the inferior rectus, that makes it very difficult to get both of those positions. And sometimes, again, you have to go to the other eye. If you've weakened one inferior rectus, now you have a duction deficit to down gaze. Sometimes you have to go to the other eye and do a posterior fixation of sorts to weaken or match the duction. We also think that when you get into the operating room, so that's planning, now we're getting into the operating room, and in the operating room, these muscles are tight. And sometimes having a grooved hook, of which you see 3 different kinds here by Doctors Wilson, Sue, and Wright, are very helpful to get underneath those tight muscles. Intraoperative adjustments, and here are some of the people that have done the work on intraoperative adjustments, are also very helpful to try and understand exactly where the eye will land. These muscles are not normal, and one thyroid patient's contracture, one thyroid patient's fibrosis, one thyroid patient's combination of those is not the same as another. So you have to take advantage of intraoperative feeling the muscle, doing force ductions and adjusting in the OR. Oscar Cruz looked at this type of approach, looking at a duction approach, trying to match the ductions on each side versus a deviation approach, doing surgery for the deviation. And in a consecutive case series comparison, he didn't find any significant difference. I think that's because both are valuable. And we use both of those at the same time in the operating room, trying to identify where we want to be with the eye. Greg Leader in the United States also looked at adjustable suture use. That's adjustment that you can do in the operating room and adjustment that you can do outside the operating room. Our group looked at adjustable sutures, and Dr. Robbins was the lead author on that. Shira, would you like to comment on what we do with our delayed adjustable sutures?
Sure. Well, this particular technique, we close the conjunctiva over the adjustable suture. And so it allows the option for a patient to have a longer period of sensory motor adaptation before we're making the decision of whether to adjust or not to adjust. So it can be certainly more comfortable for the physician surgeon as we have more data to make that decision over. A patient is not waking up being groggy from anesthesia and having to focus and try to fuse right at that time. Thank you.
Thanks so much for that. It's been a valuable addition to our armamentarium. And even sometimes small things can mean a lot. It's been said that in thyroid eye disease, a little bit of surgery gets you a lot, and sometimes a lot of surgery gets you very little. And I find, and we find, that sometimes small opportunities can make big changes. And here you're seeing just a small procedure of a central tenotomy, leaving a hole in the muscle, which normally can get you maybe 2 to 4 prism diopters, and sometimes doesn't even get you anything. And in thyroid disease can get you 6 prism diopters or even a little bit more. So sometimes you can take advantage of these tight muscles and be able to make a difference. Our group looked at and surveyed doctors around the world for Pullton-2 syndrome, where the muscle splits, usually about 8 millimeters back or 15 millimeters, 8 millimeters back from the insertion or 15 millimeters back from the limbus, which in the inferior rectus is right about where the capsule palpebral head inserts from the inferior retractors. And what we found is that the most common reason that this occurs is thyroid eye disease. And it truly is the pits when it happens. So please be careful and thoughtful about pulling on those muscles. We also noted that our surgery has a secondary effect, like much of what I've talked about, including that the proptosis can change. Remember, these muscles are acting almost like leashes, holding on to the globes. And when we release them and set them back, the eye can shift forward. And what we demonstrated is that when you operate on, for example, multiple muscles, you can get 1 to 1.5 millimeters of an increase in proptosis, which should be taken into account as you take care of the patient. So let's start to put this all together. Strabismus surgery should be deferred until after decompression, if a decompression will be done. Generally, we do recessions on the inferior and medial rectus. Often we find that undercorrecting the vertical, if it's one eye that you're operating on, helps because the inferior rectus is one of those muscles where we sometimes see a slow, late overcorrection. We aim for below primary just slightly, and that gives people primary and down gaze because they can move their head a little bit. An asymmetric problem often means an asymmetric solution. Resections can be okay. We typically keep those to the tendon of the muscle and stay away from the inflamed and involved muscle when we can. And then don't forget about proptosis and the use of botulinum toxin. The inferior rectus, if you're operating on both, should typically get the same type of surgery. In other words, if you do an adjustable suture on one, you should do an adjustable on the other. And that way they will progress together and you can aim for them to be aligned. And multiplanar solutions are perfectly acceptable. You can treat the horizontal and the vertical at the same time. Because we're spilling antigen, and in our experience have seen some people reactivate after the strabismus surgery, just like they do after getting radioactive iodine sometimes, we use steroids, a Medrol dose pack, which is a 6-day course of tapering steroids at the time of surgery to help prevent the immune system from getting involved. Additionally, because sometimes you're operating on several rectus muscles and these muscles are already swollen and may have affected the blood flow, we'll often get an iris angiogram to make sure that our blood flow is okay. We also know that these patients have these large muscles that may be indenting or shifting the globe. So we looked at and published refractive changes. And what we noted is about half will have a spherical change, a third a cylindrical change, and 50% have an axis change on their spectacles. We tell people not to buy new glasses until after their surgery. One of the other issues that comes up is, why do we wait to operate on the eyelids until after the eye muscles are operated upon? Well, there is the connection between the capsulopalpebral head and the inferior rectus, and a similar but less robust connection to the superior rectus. But additionally, we have a Hering's Law problem. Here's a woman who she's trying desperately to lift her left eye because it's low, and her eyelid is going with it. After her inferior rectus was operated on, you can see the position of her eyelids improved without doing eyelid surgery. That's why the order becomes so important. Can we return people to their normal appearance? Well, here's one of our patients that came in at the height of his disease. That's what he looks like after. But did we get him back? Well, to much younger, but he does look like himself, which is what people want. And here's another example of a woman at her worst after the surgery and what she looked like before. If you can return people to themselves, it means a lot, and it makes a huge difference. How long does it take from the time people are diagnosed to the time they're finished? We found, looking at our data presented at the American Academy of Ophthalmology, that it's almost 3 years, 33 months from diagnosis till we're finished. And once we start operating, it's about 9 months to finish the repair. And now we have this new thing called teprotumumab that we have to figure out where that fits in. So teprotumumab is a drug that was originally investigated for the treatment of hematologic tumors. Eventually, though, it was repurposed for the treatment of thyroid eye disease, and in the United States gained fast track status to allow it to be moved quickly. The data that they had and they developed showed a significant decrease in proptosis, which was the main outcome. A little over 3 millimeters of proptosis improvement, and the clinical activity score improved. What about diplopia? Well, we don't have great information, although the data originally said that it could improve. That was done using something called the Bond-Gorman scale. I was completely unfamiliar with that in the study that was used, and I asked many pediatric ophthalmologists and strabismologists. None of the people that I spoke to used this. It's a scale that uses a patient subjective report. And basically, if one eye goes down and then the other eye goes down, that's considered an improvement because now the patient's gotten rid of their diplopia. So we don't want to use that. And Bartolena's group in Italy has suggested that it not be used in randomized clinical trials because of that problem. So what don't we know, though? What we don't know is what the impact of teprotumumab is on ductions and versions. We don't know what the actual deviations were in horizontally or vertically. We don't know the single area of single binocular vision or the change with treatment or any of those above. Or can you use Botox in this setting? We don't know any of that. But what we really don't know is, when do we operate? Do we have to change how we operate? Are there risks of surgery like Polton 2? How do we know when the patient's stable? And how do we make these decisions? So we look back at our data and we look back at 27 cases with thyroid. And what we found is that the vertical deviation was the most improved with the treatment of teprotumumab. And as you can see, the far left, its superduction improved mostly in the severely restricted eye. There was some mild improvement horizontally, but vertically was the biggest. And let me show you an example of that. Here's a patient on slide left that you see that has difficulty looking up at their left eye. And then after teprotumumab, the ductions have clearly improved. And that's typically what we see. However, we still haven't answered all the questions we want, although we do know that there is some improvement in change with strabismus. So strabismus surgery should at the very least follow the use of teprotumumab. We found that almost 60% of our patients still need strabismus surgery. Let me give you a very quick example of a patient who came to see us. He was a doctor from San Diego, but had moved to Spain and flew back to see us. This is what he looked like before and now what he looked like after his disease had hit. He had a decompression elsewhere before he came to see us and was very frustrated at what he looked like. And he was then given teprotumumab. You can see the large angle deviation. And I'm going to show you our actual handwritten exam sheets that showed that he had a deviation that was as high as 75 prism diopters of esotropia and mild deficit of looking up, -1 to 2. And we talked about it, and you can see right there in the slide, I talked to him about Botox, stage surgery, the possibility of Botox and surgery, and all the different options as a good carpenter should when they go to fix something. And we went into the operating room, and I did large bimedial recessions. I did a central tenotomy in his left eye to try and balance the duction movements. And I used Botox because I did not think that the recession would be enough. His muscles in the operating room were much more elastic than the typical thyroid eye disease. And I can attribute that to teprotumumab, but it's an N of 1. Although in most of the ones I've seen since then, I see more elastic muscles. Typically, teprotumumab is given earlier in the disease. So it just may be when the intervention is done that makes the biggest difference. Well, he overcorrected, which is what we wanted, and we saw an exotropia. It is right out of his chart, and he still had a vertical deviation. We were unable to completely fix that. But he, if you looked much better, and his ductions had improved. So then we decided to get oculoplastics involved because after my surgery, he had an increase in his proptosis. At the same time, we both went in. They helped his lids because the patient was flying in, so we violated our own rules, and removal of fat was done at the same time that I did an inferior rectus recession on the right and an inferior rectus recession on the left, asymmetrically, and I did a central tendon plication of the right lateral rectus and a central tendon plication of the left with a small downshift to help the pattern that he had. And he looked a lot better. We're getting there. But his deviation still showed that he had a vertical that we had not fixed. His pattern, though, now was much better in terms of his horizontal deviation. So here he is afterwards, and we decided that since he could fuse and he was frustrated, we'd go back one more time, and on forced ductions, it was clearly his superior rectus that was tight. We had done an iris angiogram previously, so we knew his blood flow was okay, and I recessed his superior rectus. Because on forced ductions, I had to release that restriction. And here's what he looked like afterwards. Still has a small deficit looking up, but now it's even. He has a small deficit on side gaze, but now the ductions are matched, and he's orthophoric in primary position and very small deviations in side gaze, and his area of single binocular vision was much better, and he is much happier. This is not an unusual situation when you have somebody with bad thyroid eye disease. You work with the oculoplastics team. You might have to do more than one surgery. You might have to get a little bit creative. You have to pay attention to those muscles and see what they feel like and learn from your own forced ductions. And with that, I'll turn it back to Dr. Robbins to conclude.
Well, we just wanted to show you just how important this is to all of the patients once you can not only improve their double vision, but get them back to looking in the mirror and seeing themselves again. And this is an example of 3 patients who are very, very happy. This disease really turns patients' lives upside down, and whatever we can do to make an impact and help them, that's what we do.
Well, thank you, Dr. Robbins and Granet. This was really wonderful. It was clear and cogent, quite comprehensive, and I actually learned quite a bit from it. I do have one question for either of you or both of you, if you have a different take on it. You mentioned the use of adjustable sutures. Many people either say they don't use adjustable sutures in thyroid eye disease because of fear of non-adherence, particularly if it's a large inferior rectus muscle recession. Others say that they do it but use non-absorbable sutures. Others use the semi-adjustable suture. What is your take on the use of adjustable sutures, and how do you tailor it differently for thyroid eye disease?
So I'll jump in quick on this, and then Dr. Robbins, I'd love to hear your thoughts. Bert, this is a really important point. The muscle is often stiff, and even if you recess it, hanging it back, it doesn't go back. So that's where the idea that sometimes when you do a lot, you get very little comes from. What we do typically is we will not actually sew the adjustable suture to the insertion if we're doing a large recession, but set it back and then recess from that point just a millimeter or two so that we try and avoid this issue. So far it's worked pretty well for us. It does not allow us as much freedom to move the muscle as you might if you hung it back 6 millimeters. We're only hanging it back 1 or 2, but it does try and get to the point that you raised, which is an important one. And then I'll note again that if we do one eye with an adjustable suture and we're operating on the other eye, the inferior rectus, we will do an adjustable on the other side to try and make sure that they heal similarly.
I was going to ask, do you use absorbable or non-absorbable sutures on cases like that?
I'm typically using absorbable sutures because I have not seen much of a difference between using the absorbable or using the non-absorbable, but I know that many people are big proponents of using the non-absorbable. I find the non-absorbable to be a stiffer suture, but I haven't found the need in my patient population.
Thank you both. Very clear and useful answers. And with that, I will say this ends the comprehensive Strabismus course from One World, One Vision lecture on thyroid eye disease. Till we meet again.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Bert Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the Board of Directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course both visually and auditorially extraordinary, and for their technical guidance of the lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.